foreign body, bone, muscles, and even contrast material. Okay? We do have different views if we talk about X-ray of the chest in this case. We'll start from chest X-ray, then we go to KUV, and then we go to the actual osteopathies, bone problems, okay? So we do have the posterior anterior view, basically is the cassette. This is the cassette right here. So the patient is facing the cassette, okay? And the X-ray beam is entering through the back, okay? So when you put structures next to the cassette, it will be seen in the actual size. So the anatomy will not be distorted, okay? On the contrary, if the X-ray beam is entering the anterior view of the chest and the cassette is in the back of the patient, that is an imaging that is not specific at all to measure, for example, the heart silhouette size, okay? So you cannot ever estimate cardiomegaly when a patient is having an AP view X-ray, okay? How do you know just by looking at the chest X-ray that the patient has a posterior anterior view or anterior posterior view? Really easy. This is the cassette. When I face the cassette and the X-ray beam is coming through the back, the position that the patient has to acquire, I don't know if you have ever had an X-ray in your life, but they tell you to do this. Yes or no?
Yeah.
Okay. So you will be seeing the scapulas completely outside of the chest. And I'll show you an example. Okay. For example, even though I typed PA view, I want you to take a look at the scapula. Do you see the lining of the scapula here? Do you see it or not?
Yes.
So it's completely inside of the chest. If it's inside of the chest, that cannot be a PA view. It has to be an AP view. So let me look at another one. If we open this one, do you see the scapula inside of the chest? Do you see the lining of the scapula inside of the chest? Not at all. So that's the only way that I can know that the view that the patient is having is the PA view. So if you see the scapulas inside, that means that my patient was standing with the back facing the cassette. So the X-ray beam entered through the front. Why? Because I have to stand like this. And in addition to that, of course, the cardiac silhouette will be seen larger.
If you
Okay?
do it.
If you do it AP. But if you do a PA, the X-ray temp makes you to do this, so the scapula will go completely to the outside. Okay? Now that we have this image here projecting, you need to understand your anatomy. Okay? So first of all, we have the clavicles, right? And the clavicles need to make a perfect T or a cross with the trachea. Okay? Otherwise, basically the patient is just tilted a little bit. Okay? So for example, if you do a portable chest X-ray, since the patient is on the bed, sometimes the patients are rotating a little bit to the left or to the right, because it's so very difficult to do this on the bed, right? Unless the patient has a standing view, okay? But if it's portable, most of the time you have some type of rotation. How do I know that I have rotation or not if I see that, well, this is kind of like a little deviated, but that's only the trachea? The only way to know if you have rotation or not, besides the fact that you're seeing a perfect cross with the clavicles, is to look at the head of the clavicles. if you look, let me just make those lines disappear. Let me show another one. If you look at the head of the clavicle, I'm not sure if you're able to see the head of the clavicle on this one. Yes or no? So if you see the head of the clavicle on the right, you must see the head of the clavicle on the left. Do you see it on the left? It's a little,
I can see it.
but do you see the margins?
No, because there's something there.
Because it's inside. So that means that my patient is like this. So it's a minimal rotation, but for you not to have any rotation whatsoever, you must see both heads of the clavicle aligned. For example, do you see these two heads? But they must be symmetric. So the same separation that I have from the head of the clavicle to the trachea must be the same separation, and it's not. You see, it still has some kind of rotation. It's very difficult for the patient to be standing in a military position, okay? So most of the time, you do have some kind of rotation. So again, now, then after that, you have a column of air. I don't know if you're able to see the difference between color, radiopaque with the density of the heart as a tissue. Yes or no?
Yeah.
So that's the superimposed air that is passing through the trachea and the esophagus. Okay? For you to have a good penetration on any x-ray, in this case a chest x-ray, you must not able to see the column of air coming from the trachea, but you also must at least count 3 to 4 spinal processes in the cervical spine and thoracic. Do you see? 1, 2, 3, 4. You see those spinal processes?
Yeah.
Or the vertebra?
That's the cervical one?
Both cervical up to here, and this is first
So
thoracic.
you only see the two last?
Yes, at least 5, 6, and first thoracic. Okay? So besides that, I want you to pay attention to my finger. Look at the column of air from the trachea, and look at, it's deviating now to the right and to the left. Do you see it or not?
Yeah.
That's basically the bronchial tree, the main pulmonary artery, deviating to the right and to the left. Okay? And this is what we called, right there, at the same deviation or branching out, the carina. Okay? That's our anatomical point to be able to determine how many centimeters above is the endotracheal tube. Okay? That it should not be more than 5 to 6 centimeters. All right?
Can you point to the carina again?
Okay. Right there.
That's where the bronchial trees deviate.
Deviate.
Separate.
Correct. So right there is the carina. So that's the triangle. All right? So then after that, you need to be able to look at the x-ray from the inside to the outside. Okay? So we're looking at the inside, we're looking at the clavicles, we're looking at the trachea, we're looking at the entire bronchial tree, right, so main, right, and left. Okay? As you can see, the right is more straight than the left. This vascularity right here is completely normal. That is no more than, if you remember the anatomy of the bronchial tree, you have the trachea, the main, you have the right, the left, but you also have the bronch and the bronchioles and the alveoli. So that ramification is basically what you're seeing in the x-ray. So that is completely normal, and
So,
that is
wait.
not CHF.
Can you go back to the other image you just showed? There, where would you, find the carina? Right there, okay, at that point. So like
It's
that.
basically that little triangle, that deviation. Okay, that end point of the deviation is the carina. And 3 to 4 centimeters above, you should have the ED. Okay?
3 or 4 or 5 or 6?
It really depends also on the size of the patient, you know, because if you are a standard patient, 5 up to 5'8" in a male, 5'9" in a male, and 5'4" female, it should be 3 to 4 centimeters. If you're taller than 6 feet, 5 to 6 centimeters, so it really depends. So we always measure no more than 5 to 6. So I always keep it at 4, above the carina. Now, if you put it too close to the carina, you have to retract. Why? Because if you put it too close to the carina, you tend to only aerate the right bronch, not the left. Exactly. Okay? So the volumes are completely different, and this patient is at risk of not only trauma but also tidal trauma. Okay? So that is completely normal what you will be seeing on the X-ray. Okay? So this is not a sign of congestive heart failure. Not at all. Alright? That's your anatomy, your bronchial tree. Okay? So if we keep going through the anatomy, more or less at the level of the 4th intercostal space, you have the aortic arch. Okay? So if you remember, your heart is tilted like this in your chest. So what you basically see the most is the right atrium, right ventricle, and a little bit of left ventricle. You don't see the left atrium at all. Okay? So what we're looking at here is aortic arch. This hop here, I don't know if you're able to see this. This is the pulmonary artery going into the lungs. Okay? So this is completely normal as well. Then you have the same thing. This knob and here, this is no more than your pulmonary artery and veins coming inside to the left atrium. Okay? So this is your right atrium, this is your right ventricle, and only this piece right here is the left ventricle. Okay? So I'm looking not only at my mediastinum and the heart silhouette, but I also look underneath. I'm not sure if you're able to see that. I'm able to see all my vertebrae and the disc. Okay? So, to be able to see, since I do have an AP view, why? Because I see my scapulas inside, even though, let me measure. For you to know that the heart size should be no more than half of a hemidiaphragm. So basically you have your diaphragms right here, right? So you basically take the larger radial or the larger margins. So this is gonna be my larger margin from the heart, right? So if you transport this into a hemidiaphragm, it's actually larger, yes or no? So you might say the patient has cardiomegaly, but it's not true. Why? Because I have an You need a PA view in order to analyze if my patient has cardiomegaly or not. That might be one question for your board besides clinical class. Okay? So then you need to also look at your cardiophrenic angle. So between the heart and the phrenic muscle, right, which is the diaphragm, is called phrenic. Why? Because it's innervated by the phrenic nerve. So you have cardiac, phrenic, so cardiophrenic angle needs to be completely clean. No fluid, no density, has to be completely sharp. And also the costal, meaning costal margin, phrenic angle has to also be clean. Okay? Why? Because if it's obscure, the only thing that you will think is that I have fluid. I have an effusion. And if you remember in pulmonary, we need at least 200 mLs of fluid to be able to feel the costovertebral angles or cardiophrenic angles. When you have a PA or AP view, meaning the patient standing, if the patient's standing up, the fluid goes down by gravity, right? So in order for you to see that fluid up in the costophrenic angles or cardiophrenic angles, you must at least have 200 mLs of fluid in there. Otherwise, you put the patient in lateral decubitus and you only need 50 mLs to see it.
The fluid is white.
It is white.
So when you say cannot say it, you back
Wait, what did I say, dark? I haven't said dark hair now. I'm talking about numbers. No, the fluid is always white. Okay? So, the costophrenic angle has to be clear, cardiophrenic angle has to be clear in both areas. You see? Cardiophrenic, costophrenic. Now the heart, remember, even though it's a tissue, has fluid, meaning blood, inside. Okay? So the density of the heart is a little lighter compared to pure fluid. Therefore, the heart silhouette has a semi-transparent view. You must be able to see everything behind your heart. So you see your ribs behind the heart. That is normal. If you do not see your ribs behind the heart, you have three possibilities. One, penetration. It was too much penetration. That's the reason why the heart silhouette is white. Okay? Second, you have a density behind the heart that could be fluid, atelectasis, or pneumonia. So that means that if you have a heart that is not semi-transparent in a chest x-ray view, you have a density behind it. And that density, based on the patient's clinical signs and symptoms, could be an effusion, most likely loculated, right? Because if you have fluid behind the heart, a fluid must go also down to the edges, right? So you have to be able to see it here too. But there's some effusions, you will see it in clinical practice, that take the form of a mass, which is called loculated effusion. So you might have a loculated effusion, an atelectasis, or pneumonia, or a mass. And the only way to know, unfortunately, is to either do a lateral view or to do a CAT scan of the chest. Okay? Then, the right hemidiaphragm is more elevated than the left. Why? Because of the liver. And in the left hemidiaphragm, you also see the projection of what's called the gastric bubble. Let me tell you that your imaging in board examination is super basic. They make you to point and name that structure, and that's the gastric bubble, okay? Why? Because air goes up, is less dense than blood or any tissue, okay? Then after that, you're gonna be looking at your bone structures. So from the inside to the outside, right? So from the inside, we already analyzed. Now coming to the outside, we already saw the peribronchial tree. Now we're gonna be looking at the ribs, right? The posterior ribs are more straight. And the anterior ribs are more oblique. So after we finish this, we have advanced almost half of the PowerPoint. So as you can see, I don't know if you're able to see these ribs coming like this. Yes or no?
Yeah.
So these are the anterior ribs.
So this is
And these are the posterior ribs. They're more straight. Okay? In a normal person, doesn't matter if it's female or male, when you tell the patient take a deep breath, what happens is that the diaphragm goes down, right? The ribs expand and the diaphragm goes down. And in a normal inspiration, in a normal deep inspiration, if you do not have increased AP diameter, such as in patients that have hyperinflation, asthma or COPD, right? Emphysema, you should be able to count normally 10 ribs, no more than that. have the first 1, 2, 3, 4, 5, 6, 7, 8, 9. I understand that I can see this here, but I'm counting only up to the diaphragm. So this is a normal person. If I count less, let's imagine that I'm counting 8 to 7, I can describe in the results that there was a poor inspiration effort. Again, the patient is not following command. If you count more than 10 before the diaphragm, I can assure that that patient has a hyperinflation disorder. That could be COPD or asthma, for example, any obstructive pulmonary condition, okay? Any questions so far? So then we look at the borders, right? And I'm looking at the ribs, I'm also looking at the actual structure of the ribs because you can have fractures in the ribs. Now, we'll be paying more attention if my patient is all bruised, you know, suspecting any type of abuse, right? Or after a fight or after a motor vehicle accident, I will be paying more attention to the ribs. Or if a patient, for example, has cancer, some pathological fractures. If the patient doesn't complain of chest pain, why would I suspect a rib fracture? I can also describe, if I see a callus, right, on the ribs, then I can say, well, the patient has an unknown age fracture, old fracture of the ribs, okay? Then I have to look at the tissue. So you have to look at the pulmonary parenchyma. And you must have pulmonary parenchyma in every single intercostal space. That means that it looks like the vascularity of the lung, it looks like spider web. So you have to have that spider web everywhere. Do you see what I'm pointing at? So those little lines must be all the way up to the top, okay? If you do not have that, and you look not only intercostally, but also in the border. Because if you at any point has an area more hyperlucency or black compared to gray, pneumothorax, okay? But not only intercostally and in the border of the costal margin, but also in the cardiac cingulate. Because sometimes when you have a pneumomediastinum, that's also air. And it tends to border the heart. Okay? So if you have a black border surrounding the heart, that's called pneumomediastinum. Alright? And that means that you either have a ruptured viscus or you have a pneumothorax. Something that has air as a content broke. Okay? Then you look at the tissue itself. You have the clavicle that you can analyze to see if there is a fracture. You have also the head of the humerus and the glenoid process of the scapula. And you also have soft tissue that you can see if there is also black spots in the soft tissue, indicating also air, subcutaneous emphysema. And when you have subcutaneous emphysema, again, what structure inside of the chest ruptured? That the air is exposed to the outside. So it's environmental, atmospheric air getting in contact with the intrathoracic air as well. Any question? No?
Oh, yeah.
So in addition to that, you have the right lung that is divided into right upper, right middle, and right lower, right? The division of right upper to right middle is done by the major fissure, and the right middle to the right lower to the minor fissure, okay? Basically, more or less at the 5 of 7 intercostal space, you have the major fissure, and the minor fissure comes like this. So pay attention to this area, more or less where the pulmonary hub is, because you might also have a line all across that only signifies that you have fluid in the fissure. That's it, okay? So that is a normal chest x-ray.
Do you have a video that we can also practice? Yeah.
I have two websites that I can send you that are from the School of Medicine.
What does, what could one look like if they have osteoporosis or if they're breaking out?
Like you darker dots, yes.
So, when you use it with air, perhaps?
No, the bone will never have hair, never.
You would just see little tiny spots all over it?
I'll show you when we get to bone.
Because basically you could see through it, essentially.
Right. It's very poronic and you see darker spots, but it will never be air because air doesn't penetrate the bone. It penetrates the tissue, bone, muscles, and fat tissue, and all the organs, but not the bone. Okay? So you also have a lateral view, which is could be standing up, and the patients put their arms up, and also lateral decubitus and oblique. We don't use oblique the most. The most common views that are used are PA and lateral. So this is what I just told you, right? So when you face the cassette, this is the X-ray beam penetrating into the back, and this is the best view to obtain. This is the AP view, and the reason why it's not accurate, even though it might be more comfortable for some patients, is because the organs are seen larger. It's like if I take a picture and you say, go away, go away, go away, I don't want to see my defect, it's because when I take a picture from far, everything is more knitted, but actually larger than it is supposed to be. I mean, if I take a picture like this, don't you see your face larger and all the details? So that's the reason why you say, go away, farther, farther. On the contrary, for the PA view, every single anatomy and size is seen as it is. So that's the reason why it's the most accurate. So then you have the lateral view standing up, and remember, if you doubt that the patient has pleural effusion or not, do a lateral decubitus. That's the question. Okay? So, again, typical and most common and most accurate, PA and lateral. Now, when you do, you can also do portable, of course, right? Chest X-ray. But when you're gonna do abdomen, of course, you have to put the patient flat, right? Or you could do it upright, but it's not as accurate because, again, air can also go up, and that makes you be confused on any type of perforation.
What do you say about
The oblique, or we don't use oblique. We use oblique mostly on extremities or cervical skull,
But you
actual
said
spine.
something that's a question, like something after, like we can argue posterior or lateral, or not sure.
Lateral decubitus, that's what you were saying. No, it was lateral decubitus.
The lateral decubitus is for pleural effusions. Why? Because again, you come in with shortness of breath. Imagine that you're short of breath, right? And now you have a history of congestive heart failure, you have a reduced ejection fraction, you know that as the history for the patient, and the patient is short of breath, you do a chest X-ray, and you see the X-ray completely normal, you're suspecting that the patient has pleural effusion, but unfortunately, if it's small pleural effusions, you won't be able to see that the patient's standing up, right? Because you need at least 200 mLs of fluid to be able to see it at the level of the costovertebral angle or costophrenic angle. So what would be the next step to do? Put the patient in lateral decubitus. And believe me, one drop of fluid in your lung will make you short of breath. So you don't need much. Okay? So having 100 mLs or 150 mLs, you won't be able to see it, but it will put the patient in so much distress. Okay? So, again, always try to do more than one view if it's possible. Okay? For example, as I told you, the cardiac silhouette should be semi-transparent, right? Well, now you're seeing that the cardiac silhouette is super dense, and you're not able to see the ribs behind it. What do I have? My patient is short of breath. My patient has atelectasis. Does my patient has a locular effusion? Does my patient has a mass? Or my patient has a pneumonia? I don't know. Do a lateral view. And if you do a lateral view, we'll see now how it's seen. Or, when in doubt, do a CAT scan of the chest, and you will see it clearly.
Why sometimes the X-ray for pneumonia is negative and then you do a CT on it?
The same way as I told you, and I explain my family members and patients. When you take a picture, right? You take a picture as far as possible so you don't see the defects. Remember that you have 77 inches between yourself, the cassette, and the X-ray beam. So this is not like super close. So the X-ray beam is right here, and I am here in the cassette. So that distance is not able to catch all the details. So it's like having a picture from far that everybody looks good until you do a close-up. So a close-up is no more than millions of axial cuts in a CAT scan. So you're basically passing the X-ray beam several millions of times in the same area. So what can you miss? Nothing. Do you understand? So that's the reason why sometimes, and I've seen it in clinical practice many times, that I have a patient with a chest X-ray completely normal, and when I do a CAT scan, it's horrible. Okay? Look at the clinical symptomatology of the patient. So this is another, even though we haven't gone through extremities yet, this is the reason why you should obtain more views. Because if you now look at an AP view, you see the normal condyle of the tibia, you don't see any fracture whatsoever, but now when you do a lateral view or oblique, you're able to see the fracture right there, okay? Same way here. I don't know if you're able to see the fracture right there. You see a line? I know that the oral parts are not the best. But do you see a line? Yeah. When you have it in front of you in your computer, you will be able to see it. Okay? The same here. You see that, well, first there's a disconnection of the radius with the head of the humerus, right, in the actual epicondyle. And here, when you do lateral view, you don't see the disconnection at all. You see the actual epicondyles connecting to the radial, but you see the disconnection there. So here, okay? So if you're in doubt, the patient has pain, the patient has crepitus, the patient has a very tender, localized area, after trauma, you don't see the fracture, do more views. You're missing it. So again, of course, it makes sense that you're not gonna send the patient down for an X-ray if the patient is unable to stand up, right? And also, I have seen practitioners that order lateral decubitus on a patient that is intubated. I mean, it doesn't make any sense. Do a CAT scan and that's it. It's actually faster and more accurate. But, you know, if the patient is unable to stand up, don't order a PA and lateral standing up when the patient has to have a portable X-ray. So also pay attention to your patient population, okay? So, and we already went through the differences between the PA and the AP and the reason why PA is more accurate. So here is the explanation why the cardiac silhouette is seen larger and you cannot actually determine the size of the heart, okay? So again, when you're analyzing an X-ray, first of all, check the film. Check the film to see if this is the appropriate patient. Because sometimes you're interpreting the chest X-ray and you don't realize that it has a tube and then your patient is not intubated or backwards. Right? Yes, it has happened. It has happened. Or my patient never had a history of cardiac cath, coronary artery bypass graft. My patient has wires or a pacemaker. My patient doesn't have a pacemaker. Do you understand, or breast, when my patient is a male. It has happened. It has happened. That is, yes, rarely, but I've seen it. I've seen it in my clinical practice. So be careful. Remember that the x-ray guys are two guys coming with the x-ray portable room to room, and they're interrupted to do another one. Come here. And that's when the problem comes. It has happened, believe it or not. Okay? Also pay attention to the name of the patient. Pay attention to left and right markers. Okay? And also the date of the film. Always compare. Always compare. And if you have the access to prior films, pull them up and compare as well. Don't look at what's happening today. That's a mistake. That is a mistake. I had a patient last week that I don't see myself as better than anybody else, but I have a training in a country that you have no resources. And I love to go back. That's the only weapon that I have. So I receive a patient, congestive heart failure, congestive heart failure, congestive heart failure. The patient was going even to cardiac cath. Congestive heart failure. Was never a patient of ours for Dr. Bosch pulmonary, but when I open up April, but this year, the CAT scan was exactly the same, and X-ray the same. I go back to January, multiple admissions, same. Patient already had a cardiac cath and stent placement, and it was not resolving at all. Last year, 2018, in August, I even remember the month because we went down to radiology. Same CAT scan, impossible. They were like, CHF versus pneumonia, because when you don't know, you just put two names. First of all, how can you have pneumonia? It could be, you can have pneumonia, more than 5 events in 2 years, but it has to change the morphology, right? The same as CHF. You can have congestive heart failure and pulmonary edema, but you're not gonna have the same morphology of the pulmonary edema every time you come. The patient had cancer. And it was missed since last year. I don't know what the patient had. We investigated after that, and we canceled everything until further investigation, and it came out results as a lung biopsy that the patient had cancer. And we were treating CHF and pneumonia.
How old was the patient?
Why? Because the simplest thing wasn't done. Go back and review. And that is the problem of liability. I'm not saying that maybe one day I'll get sued, but I'm very, very, very careful. Because you could be sued just because of that. I understand that since 2018, it hasn't changed, but we did not go back further on prior CAT scans. You never know if that CAT scan was better in 17 and it progressed to the point that there's no way back. And the patient can claim that in the court. And forget about who saw them this year. We'll also go to court with everybody else. All right? So please compare. Always, always, always compare. Okay? So, because it was pneumonia, an aspiration pneumonia, or of course CHF, with an ejection fraction of 55%, and no valvulopathies, no diastolic dysfunction, and already a cardiac cath with two stents placements. And the patient was the same. It did not change. Listen to your patient. Okay?
Hopefully it's not like
So If it's a matter of bones, where we're gonna go through the hands and shoulders and knees and all that in a second, look at the alignment. You need to know your anatomy. Okay? Look at the soft tissue, as I told you, for air. Because if you don't see the fracture, if I right now have humeral fracture, which it has to be visible, but if you don't see that and you see soft tissue swelling and you see air in the soft tissue, that is indicative of a fracture, even if you don't see it. Okay? And also look at the organs, because sometimes the patients have a kidney, nephrectomy, and you don't see one kidney. Well, where is it? Was it agenesis, that the patient was born without a kidney? Or was it the patient had a cancer and it was removed? What happened? Or is atrophy, that I don't see it and I have to do an ultrasound? That guides you to ask the patient, because many patients did not think that one particular history is relevant to their diagnosis. Okay? So I'm not gonna go over the entire anatomy because I already went through that, right? So we can skip that. So look at the lateral view. In the lateral view, you have what's called two diaphragms, but it's not reality that you have two diaphragms. Remember that the right diaphragm is more elevated than the left. So when you do lateral decubitus, you see in the lateral decubitus two diaphragms. And that does not indicate that you have bowel rupture, right? Not at all. Remember that when you have a rupture of a bowel, rupture of a viscus, air goes up and you see double diaphragm in AP or PA view, right? You had that as a question on your test once, right? Well, that is not true when you do a lateral decubitus in a normal patient, because when you do a lateral decubitus in a normal patient, it's normal to see two diaphragms because there's a superimposition of the right and the left, okay? So that's completely normal. So again, going through the anatomy, I know this is not the best view, but you have the spine and the back. You have the aorta, arch, descending, and you have the pulmonary trunk, and this is the heart, okay? All right, so you have the right chest anterior and posterior, all right? And this is the entire anatomy that I already went through that. This is what I told you, that you have to look at the clavicles, they have to actually look straight, count down the anterior and posterior ribs, more or less, no more than 10. So we counted 9, right? So 8 to 10, no more than 10. If you count more than 10 in inspiration, that means you have a hyperinflation, okay? And you have to think about either asthma or COPD, any obstructive pulmonary condition, okay? So again, as I told you, either hyperinflation or hypoinflation, meaning that now I'm counting until 6, 7, you're either chunky obese, right? And that's the reason why you have a short AP diameter, or you're not inspirating enough for a chest x-ray. Either because you're in pain, for example, if you're a normal person and you're standing up, or you're non-cooperative, or the patient is in a portable view and is not cooperating, okay? So you would see hypoventilation in that case, okay? So again, remember the view of the chest x-ray that I show you? Basically the posterior ribs are more attached to the vertebral, right? And the anterior to the sternum, and also count the spaces that you know that is seen in black. So this is what I went through already. Also, we said that the normal cardiac silhouette, I explained that it shouldn't be more than half of the hemidiaphragm, right? So if you have in a PA view, which is the most accurate, you have a cardiomegaly, what would you think besides those 3 that are labeled there? Well, I either have a pericardial effusion, right? I have a cardiomyopathy, right? So either left ventricular hypertrophy or right ventricular hypertrophy, because those two can enlarge my heart silhouette as well. Or I have congestive heart failure, right? And again, as I told you, you can only determine the size of the heart if you do a PA view, no AP, no lateral. So again, you measure the heart to the largest width, and you transport that. Of course, we have a better technology in hospitals, right? When you open packs or centricity or whatever platform you use, we have measurements on top and even magnified glasses and everything. So you can transport that measurement and measure exactly. So if you transport the biggest width into a hemidiaphragm, it shouldn't be more than that. If it is in a PA view, you have cardiomegaly. All right? So as I told you, look at the costovertebral angle, costophrenic angle and cardiophrenic angle to see if you have any type of fluid. They must be sharp, right? And also look at all the lobes. We're gonna go through the lobes in a second. So this is what I told you, that the division between the upper and the middle lobe, you have the fissures, right? Major and minor. And look at the fissures as well to see if you have any type of fluid in there. Now, what will you see, for example, if you have pneumonia?
What?
You see a density, right? You see a density, which is called silhouette sign. Basically, it's no more than a consolidation. It's an infiltrate, it's called consolidation, infiltrate, density. Radiologists label it as that. But remember, it's not the radiographic imaging what determines what the patient has. Because if you have an infiltrate, that infiltrate could be atelectasis. How do you know it's atelectasis versus pneumonia? Symptoms. The patient just left the OR and it's 24 to 48 hours. You went through the cause of fever already, right? Most likely it's atelectasis. Why would I think that the patient has pneumonia unless somebody did not screen the patient properly and the patient went to the OR already with community-acquired pneumonia? That's different.
Or
But you would have more symptoms, right? Like productive cough, yes, fever, and maybe family members with the same symptoms. So you have to investigate that. It's your job to put diagnosis to an imaging finding, okay? The radiologist only will tell you there's a right middle lobe consolidation. That could be pneumonia versus effusion versus atelectasis. He doesn't know. He doesn't have the clinical expertise. Okay, you do. Have you read that in reports? They have to tell you that. It's not that they don't know. It's that they don't have the patient in front of them. Okay? So again, if, for example, this is basically anatomy. The right lower lobe, remember that I told you that, which I don't agree with Barkley. When you have, let's talk about the right side, okay? You have right upper lobe, right middle lobe, and right lower lobe. When you have a density in the chest, you have no idea where it's located. Let me just open it. Let me give you an example. For example, imagine this. How would you describe that? I would say right middle lobe consolidation, or actually it's more than that because I have it bilaterally. I can say multi-lobar, multifocal, but I see the most, if I will describe the lobes, right middle lobe. Why? Why not upper? Why not lower? Well, I cannot assure you that it's upper or middle, but I can tell you 100% that it's not lower. And the reason why is that I don't agree with Barkley is that you see the diaphragm. Clear. When you see sharp borders of the diaphragm, that lesion is not located in the lower lobes. And that also applies to the left. Do you understand? You can say that this is middle or upper. Of course, I'm more inclined to tell you middle. Why? Because it's below the fissure, right? Isn't it 5 to 7? So I have it below the fissure. That's the reason why I tend to see middle. But you would not be wrong if this is right upper, right middle, but it will be completely wrong if you say the right lower. Because I'm able to see the diaphragm clearly. Let me show you this.
What does Barclays say then?
I'll show you. Versus I understand that you see it, but do you see it clearly?
No.
It's kind of like a haziness, right? Between the whiteness and my diaphragm. If I pay close attention, yes, I'm able to see the diaphragm, but I don't see clear borders. So that's the reason why it's right over here. Now, can I know that this is, if my patient is, which is not, it's actually a PAU, but imagine that my patient is laying down. Would I be able to say that this is fluid versus pneumonia versus atelectasis? No, you can't. Clinical symptomatology. It's only right lower lobe infiltrate. Correlate with patient's symptoms. That's what the radiologist will tell you. Okay? Now, of course, if you have a right lower lobe infiltrate, not only the heavy diaphragm will be obscured, but also the cardiac silhouette will be obscured, isn't it? That's the clinical pattern of a right lower lobe as well. So again, look at this. It's not a clear diaphragm. It's not a clear diaphragm. It's not a clear cardiac silhouette, even though I'm able to see the diaphragm. Do you see?
Even though that one will be considered like lower lobe, even though it's like,
Which one?
that one, the last one you mentioned.
This one?
Because
It's right lower lobe. Why? Because the characteristics of the right lower lobe, not only as I told you, the diaphragm is obscured, but also the cardiac silhouette is obscured. Okay? Any questions? No? So, as you can see, it's a little contradicting here because as you can see, look at the right lower lobe. Blunts the hemidiaphragm, isn't it? Right lower lobe blunts the hemidiaphragm. Then he puts an example of a right lower lobe pneumonia, which this is not an obscuration of a cardiac silhouette because I see it clearly, right?
Yes.
This is no more than a bronchial tree. Now, if I see that this density is not allowing me to see the cardiac silhouette, yes, it's the right lower lobe. You understand?
So that one is not a right lower lobe.
It's not the best picture. He's pointing at it like, oh, this is right lower lobe. You see the arrows? Why? Because it's trying to tell me the cardiac silhouette is obscure, even though I'm able to see the heavy diaphragm.
So you can't see that.
But I can actually see it, so it's not the best picture.
I think I'm not understanding, but why is that not middle lobe, for example?
No, it's not middle lobe because it's not occupying, it has to occupy like that, horizontally.
And so what you're saying with Barclay is that they're saying, what exactly about this?
I don't know how it's going to be explained when you get the seminar, but if he explains, listen, if he explains, or whoever is teaching, that if you don't see that the diaphragm is right lower lobe, or if the cardiac silhouette is blunted, is also right lower lobe, it is correct. Do you understand? I believe he's trying to point here as this density obscuring completely the cardiac silhouette, but it's not the best picture because I can see it clearly. To me, that's the bronchial tree. Do you understand? The best pictures will be the one that I show you. Either blunting, what would this be? Middle. Lower. If you have to name this, what will you do? here only. Here's middle, but do you see the heart being transparent behind? Question to you. Do you see the heart being semi-transparent? No, it's completely white. Do you see it or not? Do you see your diaphragm here? No. So I have basically multifocal. I have it in the right lower lobe, left middle lobe, which doesn't exist, it's called lingula, and left lower lobe. I have multifocal, multi-lobar infiltrates, okay? This is the best picture for him. Do you understand?
For the right lower lobe.
Right, I would have substituted his picture for a picture like this,
No.
because you're not able to tell me where's the heart line. I can't. That would be right lower lobe.
And that chronic angle, you can't really distinguish.
Correct. Okay? So if we do, again, when in doubt, you could do a lateral view, okay? And again, you have your spine, you have your trachea, okay? You have your heart presenting here, but you're not able to see the vertebrae completely, so that's the reason why it's pointing that when you don't see your vertebrae completely, it's even one, density is really high. So the technique that the radiology technician apply, too much amps or voltage, right? That's why I penetrate it and put it wider, and I can't see it. Or this is a consolidation, if I'm not able to see the spine. Again, if you compare the right lower lobe, look at the blue. The blue says that the right lower lobe blunts the hemidiaphragm, but the right middle lobe goes above the diaphragm. So again, the rule is that if you're able to see the diaphragm, you do not have right lower lobe. If you're able to see your cardiac silhouette, you do not have right lower lobe. Okay? It has to be middle or upper. Again, if you look at an image, are you able to see diaphragm? Yes, so therefore, right middle. Okay? If it's above the fissure, then it will be right over. Again, remember, you have the cervical spine, and if you recall the prior lateral view, what was supposed to be here? The heart. Yeah, right? And then a diaphragm. First of all, you don't see the diaphragm. Second of all, you don't see the heart. Okay? So, I would say that this is right lower lobe instead of right middle lobe, but he has a label as right middle lobe. Why? Because I'm not able to see the diaphragm, and my cardiac silhouette is completely wrong.
That's always my confusion, when you have it like that, how you go against the patient doesn't have any history of CHF, because you're white out, when it's white out, can be fluid too.
Of course, that's the reason why. Do you have any cough? Any phlegms? What color? White versus green. Fever, no fever. Any families at home? Have you been hospitalized recently? You're going through the risk factors and symptomatology of pneumonia to rule it out. Otherwise, it has to be fluid. Okay? I understand that in the hospital, everybody goes through empiric antibiotic treatment and Lasix. It doesn't make any sense. If you have infection, you have to give fluid. How can you give diuretics? It's because you're pointing at everything. Okay? Yes, it's true. Then you have right over above the fissure. And again, if you have the right over in a lateral view, you're able to see the heart clearly, and it's above the heart. You're not listening to me. So again, you would not be wrong. Nobody's gonna test you. Say right over, right lower, right middle. No, it's not like that in your board examination. But in clinical practice, if you say this is right middle of pneumonia, it's not wrong. Now, the problem is that you have to know your anatomy. And remember, by the 5th to 7th, you have not your fissure. So if it's above the fissure, right. So if it's, let's put it this way. The closer you get it to the aortic arch, which you have the pulmonary hub there, is over. Lower than that is middle.
Can you compare a pneumonia with a pleural effusion?
Well, if you have an effusion right here, hello, if you have an effusion right here, it has to be loculated. Because when you pour fluid in any container, it has to go down. It has to go down. Not even the fissure will stop. The fissure is not like a barrier.
Right.
It's just an anatomical lining, okay? So it has to go down, unless it's loculated. And if it's loculated, it's old. It has created already a coating of fibrotic tissue, okay? So
Yeah.
you can say that it's a loculated effusion versus a pneumonia, but I would not be able to tell you the difference based on x-ray.
You have
Patient. And it's the truth. When you start practicing, you say, yes, she was right.
I mean, I'm doing meditation with someone, I'm telling you, like, every patient is like, rule out the fusion pneumonia, it's all the same.
But who's the job to rule it out? Yours, not the radiologist.
Right.
It's yours. It's just that we don't use the stethoscope and we don't talk to the patient. That's it. That's the problem. I have seen cardiologists and pulmonologists with that. Okay? So again, we went through the entire anatomy. This is just a child, but when you're not going to be testing a pediatric. Now, he has some questions here. Which object will appear the densest? So the density, the higher the density, the wider you will see, right, on an x-ray. The lighter the density, the darker it will be seen. So if the densest,
It's the whitest, so it would be.
you will be between glass and muscle, right? Okay, fluid is white, air is black, glass is white, muscle is gray. You want me to go back to the scalp?
glass, it was here is white. It is white, there is black.
Glass is black.
So the densest of the three, muscle, bone, and barium, right? Yes or no? Air, black, fat, black, muscle, bone, which is actually white. He has it as light gray, and barium. You come here, fluid, air is black, this is bone, okay? You have glass, which is dark, and muscle has to be gray. So between those, so again, low density, black, air, and fat, for example. Radiopaque, which will be high density, will be white. Examples are bone and barium. But he doesn't have the fluid, right? And the fluid is really white. So in the scale, okay, in the scale we have air, black, glass, black, muscle, gray, fluid, white. So which is the densest? The less dense an object is the darker will appear on the x-ray. Then the basic view, the most accurate view, PA and lateral, right? And to be able to estimate the size of the heart, you have to do PA. I guess he will make you to vote. It looks like it, right? Like the clicker. I don't know. Here it says, when evaluating a chest x-ray for pneumonia, you evaluate the cardiac diaphragm silhouette to determine the lung load involved. What would your findings be for right middle lobe pneumonia? right middle lobe. The diaphragm borders will be lost. Out. Both the cardiac and diaphragm borders will be lost. The cardiac border will be lost, but the diaphragm border will remain. Any questions? Take a break, we'll do KUB, and then we'll. Yeah, we'll like fractions.
Gracias, termino tú.